Hello again, and welcome back to part 2 of this year's edition of the most commonly missed keyword topics on the ABA's Anesthesiology in Training examination within our residency program here at Robert Wood Johnson. This is the 2025 edition. This review is a continuation from part 1 of the review and covers keywords on which our residents did at least 7% worse than the national average. By paying special attention to these keywords, we can help to close gaps in knowledge within our residency program and help you all to be more successful on your upcoming boards this summer. As a refresher for how to use these slides, the percentages in the upper right-hand corner represent the percentage of residents at our program that answered the question on the ITE related to the presented keyword correct when compared to the percentage of residents from around the country that answered the same question correctly. The questions are loosely grouped into 5 different categories, each represented by an image below. They are basic sciences, clinical sciences, organ-based sciences, clinical subspecialties, and special issues in anesthesiology. The question types that are in part 2 are those within the red rectangle there. Okay, our first keyword here is for part number 2 is Duchenne muscular dystrophy and anesthetic management for those patients. So Duchenne muscular dystrophy is an X-linked syndrome that results in abnormal expression of dystrophin. This is a protein necessary to muscle cell integrity. It generally presents in early childhood and has many manifestations with varying severity. Key characteristics of this disease include progressive muscle atrophy, most commonly seen in the proximal extremities, cardiomyopathy, and respiratory difficulties due mostly to diaphragm weakness. Some children experience developmental delay also. When providing anesthesia to these children, there are several key considerations to keep in mind. Depolarizing neuromuscular blocking drugs such as SUCs are contraindicated as they can result in extreme hyperkalemia due to proliferation of immature extrajunctional acetylcholine receptors. Halogenated agents may cause muscle breakdown and lead to rhabdomyolysis. Non-depolarizing neuromuscular blockers may be used, but these should be used with caution as the onset of action is often slowed and the duration of action may be prolonged. If you examine this diagram over to the right, there are some other interesting facts about Duchenne muscular dystrophy that you can learn. Our next keyword here was presented by Jared at Case Conference a week or so ago. It is GCS and indication for intubation. So GCS, or the Glasgow Coma Scale, takes 3 neurologic exam components and assigns a score to each one of the 3. As the image indicates, these are eye-opening, which is worth 4 points, verbal response to questioning, which is worth 5 points, and motor response to stimulation, which is worth 6 points, for a grand total of 15. The need for intubation is often cited as occurring at a GCS of 8 or below, and the reason for this is that the degree of neurologic impairment often results in the loss of protective airway reflexes when the score drops down to this level. This is not a hard cutoff, however. Each case is unique and should be treated as such. Other considerations should come into play, including respiratory function, hemodynamic stability or instability, and also the rate of deterioration of the GCS status. The more quickly the deterioration, the more likely you should be to protect the patient's airway. And as we wrote here in capital letters, not every case is the same. We must remember that, although in general, a score of 8 is when we should start to think about airway protection. Our next keyword in the organ-based systems category is hepatic blood flow and anesthetic effects of this blood flow. So in general, hepatic blood flow is quite complex and relies on many different factors. At its most simple, 75% of blood flow comes via the portal vein and 25% comes from the hepatic artery. Another teaching point on top of this, that is that in general 50% of oxygen delivery to the liver comes from each. That is oxygen-rich blood flowing through the hepatic artery provides 50%, and 75% of flow through the portal vein is oxygen poor, and that provides the other 50% as well. Because the majority of flow comes through the portal vein, and blood from the portal vein comes from the splanchnic circulation, flow through the portal vein is variable due to changing demand of the splanchnic circulation. When more blood is in the splanchnic circulation, for example, after eating a large meal, a buffer system is employed that dilates and increases flow through the hepatic artery. Anesthetics can affect this buffer system, and most will decrease hepatic artery flow by decreasing blood pressure as well as inhibiting the buffer system. Propofol has been shown to affect this less than other agents that decrease blood pressure and cardiac output, and one study even showed an increase in hepatic artery blood flow with propofol. Here we have a classically tested keyword. It is the differences in the infant versus adult larynx. As you can see in the upper right corner, our residents did pretty well. 75% of our residents got the related question correct, although the rest of the country did slightly better, so it's a good opportunity to review this keyword. So, in general, I have some characteristics listed here to the left, and we can compare the pediatric and adult airways. So in general, the shape of the airway in children is more cone-shaped, while the adult airway is more cylinder-shaped. The pediatric airway is located a bit more cephalad than the adult airway. The tongue is relatively larger in children when compared to adults. Breathing in children, most young infants are primarily nasal breathers, while adults are oral breathers and also can breathe well through the nose. The head is relatively large in children. This, when lying supine, will encourage the child to have a natural flexion of the neck in the supine position. The epiglottis is somewhat more floppy. It's also classically described as being omega-shaped, while the adult epiglottis is a bit more stiff. The cords have a more anterior attachment, and it creates a bit of slanting of the vocal cords, whereas the cords of the adult are more oriented 90 degrees during laryngoscopy. The tracheal length in young children is quite short, which makes main stem intubation significantly more likely in children. The adult airway in average size adults is somewhere between 10 and 12 centimeters. Children tend to have more highly reactive airways as well and are more prone to flow restriction by way of bronchospasm, and those with asthma are more prone to asthma exacerbations as well. Moving on to obesity and lung volumes. So when discussing lung volumes and capacities, it's very important to remember that capacities are simply two or more volumes that are added together. When thinking about this topic in obesity, a restrictive pattern is usually followed, caused mostly by reduced chest wall compliance. When all patients, but especially patients who are obese, go from upright to supine, then to Trendelenburg, the abdominal contents shift cephalad and pushes up on the diaphragm. This results in reduced FRC, functional residual capacity, mostly due to a decrease in the expiratory reserve volume portion, while residual volume is generally preserved. Expiratory reserve volume is the most sensitive indicator of the effect of obesity on pulmonary function. When the FRC decreases below the closing capacity, and the closing capacity being affected by age, not obesity, the small airways can close, which results in ventilation perfusion mismatching. Induction of general anesthesia in an obese patient may decrease FRC by up to 50%, whereas in a non-obese patient, FRC may only be reduced by about 20% or so. Thyroid surgery has many pitfalls, and appropriate monitoring for 4 to 6 hours after the procedure is complete is imperative to preventing several catastrophic complications. The first consideration is calcium monitoring. So hypocalcemia may occur if the parathyroid glands are either damaged or inadvertently removed during surgery. The next thing that we have to be cautious of is recurrent laryngeal nerve injury. This is perhaps the most commonly talked about injury after thyroid surgery. This can result in symptoms that range from mild if unilateral injury is involved, and the main symptom is generally hoarseness, to stridor and respiratory distress with the more rare bilateral recurrent laryngeal nerve injury. Hematomas are a potentially catastrophic complication as well. The main reason for a prolonged PACU stay after thyroid surgery is that the majority of hematomas occur within the first 6 hours after surgery. Finally, a significantly more rare complication that one can find after thyroid surgery is tracheomalacia. This is a rare complication that can happen if there's compression of the trachea over the long term, and generally these are due to extremely large goiters. All right, so the boards love to test SIADH, diabetes insipidus, and cerebral salt wasting syndrome by asking questions about the physiologic derangements and presentations of these diseases. As you can see from the stats up on in the upper right-hand corner, only 20% of residents at our program got this question correct, and about 30% of residents throughout the rest of the country got this question correct. And so I'm willing to bet that this question was focused on some of the more rare treatments toward the end of the line rather than the more common treatments such as free water restriction. But it's important in general to understand the pathophysiology and presentation of SIADH as well. So in general, SIADH is a collection of symptoms that result from the body secreting too much antidiuretic hormone. This results in free water retention and hyponatremia with low serum osmolarity. Urine osmolarity will be high as antidiuretic hormone will cause the kidneys to concentrate urine. Though care of these patients is generally in the intensive care setting, patients may be encountered perioperatively as well. Electrolyte imbalances can cause challenges in fluid shifts and arrhythmias, and rapid correction of hyponatremia, especially when severe, may lead to central pontine myelinolysis or even seizures. So first-line treatment, as I mentioned, includes free water restriction, hypertonic saline. This is generally reserved for patients with severe hyponatremia when, for example, the salt levels dip below 120. Loop diuretics, which eliminate free water, and dimeclocycline. Now, dimeclocycline is an antibiotic that blocks the release of antidiuretic hormone. Perhaps what this question was about was the less commonly used Vaptan drugs. These are vasopressin receptor antagonists, which block the action of already released antidiuretic hormones. So all of these treatments can be utilized, generally starting with free water restriction and moving on to the pharmacologic agents. Our next key word here is sodium bicarb indications. You can see from the upper right-hand corner, this was a very commonly missed question, both at our program and around the country. And the FDA really has only approved sodium bicarb for 3 main types of problems. So these are acute or chronic metabolic acidosis, urine alkalinization, and dyspepsia. So if we look at the acute and chronic metabolic acidosis list, we have a wide range of different disease states that result in acidosis. So anything from bicarb loss through the kidneys and renal tubular acidosis, uncontrolled diabetes, primary lactic acidosis, severe hydration, cardiac arrest, hyperkalemia, or significant diarrhea with bicarb losses, sometimes sodium bicarb may have some benefit here. Now, with acidosis, it's important to remember that sodium bicarb is really only indicated when the acidosis becomes severe, and that's usually classified as somewhere between 7.1 and 7.2, or at least less than 7.2. Or if you have a very rapid trend toward significant acidosis. At this point, acidosis creates other deleterious physiologic effects, such as coagulopathy, arrhythmias, and hypotension. Looking at urinary alkalinization, this is usually reserved for different overdoses or poisonings, for instance, salicylate poisoning or barbiturate overdose, or overdoses of other particularly acidic medicines such as TCAs. It can also help to enhance uric acid excretion for situations when it's important to excrete uric acid, such as with gout attacks. Now, with dyspepsia, these are our oral solutions, so different formulations of baking soda, such as Alka-Seltzer. It's important also to note sometimes is asked how to dose sodium bicarb when the decision has been made to give it. So the shortcut here is that you multiply the base deficit by the weight in kilograms and then multiply that value by 0.3. And that will give you the number of mil equivalents to dose. Our next keyword is management of torsades de pointe. You can make fun of my pronunciation later, but in general, torsades de pointe, or twisting of the points, is a polymorphic ventricular tachycardia that may be self-limiting or may dissolve into ventricular fibrillation. It is associated with QT prolongation that is either congenital or acquired. Most patients with torsades are asymptomatic, and many episodes will spontaneously resolve. However, up to about 10% of patients present with sudden cardiac death. The first step in acute management is to determine if the patient is hemodynamically stable or unstable. If stable, an attempt to reverse modifiable risk factors such as discontinuing QT prolonging medications and electrolyte disturbances can occur. Magnesium is the first-line medical therapy and should be given in both bolus and in infusion forms. Now, if the patient is unstable, synchronized cardioversion can be used. This can, of course, only be used if the patient has a pulse. If the patient does not have a pulse, defibrillation should take place immediately, as well as following ACLS protocols. Other therapies may include increasing the heart rate to try and prevent the R-on-T phenomenon, which can sometimes kick off torsades, or if the patient has this ability, overdrive pacing may be effective to raise the heart rate in this way. Our next keyword is pharmacologic implications of aging. So it's often easiest to break down anything having to do with pharmacology into pharmacokinetics and pharmacodynamics. Of course, pharmacokinetics describes what the body does to the drug, whereas pharmacodynamics describes what the drug does to the body. So looking at pharmacokinetics, as we age, absorption tends to decrease. The volume of distribution changes also depending on the properties of the drug. So with more lipophilic drugs, because total body fat content tends to increase as we age, volume of distribution tends to rise. And since total body water tends to decrease, volume of distribution tends to decrease with more hydrophilic drugs. Excretion will change as renal function tends to slowly decline with age, and protein binding may also be reduced if elderly patients are in a state of malnutrition. So pharmacodynamics are different based on the different types of drugs. So actions of various drugs can either increase or decrease. So looking at the chart over here on the right, we see some drugs can have increased action, such as diazepam, diltiazem, verapamil tends to increase, Coumadin tends to increase, and some medications will tend to have decreased action, and some will not change all that much during aging. Okay, here we have lab evaluation of carbon monoxide toxicity. The gold standard for assessing the degree of carbon monoxide toxicity is carboxyhemoglobin. I'm willing to bet that the question on the ITE had to do with levels of carboxyhemoglobin and the extent of the toxicity, though I really cannot be certain. These questions sometimes can be asked in a variety of ways. So we'll go through a couple of different things on the topic. So a normal level of carboxyhemoglobin in non-smokers is somewhere between 3 and 4%. In smokers, this may be as high as 10%. When looking at monitoring and lab work, PaO2, P little a02 that is, or the partial pressure of oxygen dissolved in blood is usually normal, and SpO2, or pulse oximetry, is accurate only if it is directly measured. If using a pulse oximeter, SpO2 may be elevated as carbon monoxide binds hemoglobin much more strongly than it does oxygen. Other lab work often obtained in suspected carbon monoxide poisoning are troponins, as myocardial ischemia in the setting of carbon monoxide poisoning is often predictive of mortality. CK and urine myoglobin, as rhabdomyolysis may be present. Cyanide and methemoglobin levels also are obtained, as these are often concurrent poisoning issues, especially when talking about smoke inhalation. And then lactate levels are often drawn as well. Now, in terms of the carbon monoxide levels and the degree of toxicity, once you get above 10%, usually 10 to 20%, these can manifest as headaches, nausea, dizziness. If this progresses above 20%, somewhere between 20 and 50%, depending on the patient's exposure to carbon monoxide chronically, you can have loss of consciousness and even seizures. And if the levels progress above 50%, that is when you can have asphyxiation and death. This keyword is epidural analgesia mechanism. Our scores here in the upper right-hand corner are not bad, but we still lag a little bit behind the national average here. So we'll go through this topic as well. So when injecting local into the epidural space, nerve roots that run through this space are blocked by interruption of sodium channels, as we've all learned before. Opioids injected into the epidural space work by binding mu receptors, as they do throughout the rest of the body, but here these mu receptors are in the gray matter of the dorsal horn. Other terms to describe this location that you may see on exams include the substantia gelatinosa or lamina 2 of Rexid. In addition to mu receptors in the central nervous system, epidural opioids eventually are systemically absorbed based on their lipophilicity and exert supraspinal effects as well. Other adjuncts, as we've listed below, can be added to local anesthetic to exert different effects as well. Clonidine may increase the duration of local anesthetics. Bicarbonate increases the onset of action due to increased pH and creation of uncharged molecules that more readily cross lipid membranes. Epinephrine may prolong the duration of the block due to local vasoconstriction and reduced systemic absorption, and steroids are often used to reduce inflammation of nerve roots. I also included a chart below that looks at 3 commonly used epidural opioids, and the chart compares their relative strengths based on the location of administration. Our next keyword that we have here is hypoplastic left heart and the management of anesthesia in such patients. So this topic could comprise lectures upon lectures itself, so I will discuss it at its most basic. One of our residents recently gave a nice summary of this, and if I can do half as well as that, I will have outdone myself. Hypoplastic left heart syndrome creates a situation of single heart physiology. That is, the right ventricle supplies not only the systemic circulation, but also the pulmonic circulation. These two circulations, furthermore, exist in parallel. Therefore, flow is based on the relative levels of systemic vascular resistance and pulmonary vascular resistance. So both oxygen and CO2 are two variables that affect PVR quite a bit, where oxygen may reduce PVR, which therefore increases pulmonary flow and reduces systemic flow and creates hypotension. Therefore, an SpO2 of usually 75 to 80% is often accepted in these patients. In the same way, hypocarbia and alkalosis can reduce PVR, which again increases pulmonary blood flow and reduces systemic flow. Therefore, modest hypoventilation is generally used in order to increase systemic flow by increasing CO2 levels. And now, though this was not expressly asked on the ITE based on how this keyword was written, hypoplastic left heart syndrome is corrected in a staged manner. I included 3 pictures over to the right, and these procedures are the Norwood, the Glenn, and the Fontan procedures. And images of what exactly is done during each are over to the right side of the screen. All right, here we have neonatal resuscitation and particularly IV fluids during neonatal resuscitation. So all in all, whether volume expansion is truly indicated in neonatal resuscitation is still a knowledge gap. In general, in neonatal resuscitation, the most important aspect is appropriate ventilation. A rise in heart rate is the most important indicator that resuscitative measures are successful. Pulse oximetry may be used to guide oxygen therapy, but ultimately ventilation is the most important measure. So if ventilation and other steps to improve ventilation, such as intubation, are unsuccessful at increasing heart rate, chest compressions may then be started. The heart rate response to chest compressions, which is monitored with EKG, should be followed, and if an appropriate response does not occur, the next step is to administer epinephrine. Failure to respond to epinephrine indicates that hypovolemia may then exist, and at this time it's appropriate to attempt volume expansion with either blood or crystalloid. Blood is preferred if bleeding is suspected, of course. If volume expansion is attempted before all of the previous steps are undertaken, volume overload is very likely, it may be caused inadvertently, and this may ultimately lead to pulmonary edema and worsening outcomes. Our image over here on the right sort of illustrates how, if in the hypovolemic setting, fluids may have some positive effect. Moving right along, we have nerve gas treatment. So when you hear the term nerve gas or read it on a test, this implies that organophosphates are involved. Now, the most common organophosphate that we hear about is sarin gas, but all organophosphates are irreversible inhibitors of acetylcholinesterase. So when you have a decreased acetylcholinesterase, this increases the amount of acetylcholine at neuromuscular junctions, causing an overwhelming effect of cholinergic symptoms. As a refresher, these include salivation, lacrimation, meiosis, bronchoconstriction, and bradycardia. Now, treatment of nerve gas poisoning includes atropine. This is mainly for management of the above symptoms, and pralidoxime or any of the other oximes. And it's important that this medication is used as quickly as possible because as acetylcholinesterase becomes more and more inhibited, you need more and more pralidoxime to overcome this inhibition. Now, the image over here on the right shows that decontamination is also an important step. And also, like we said, rapid access to treatments is important in treatment of organophosphate poisoning as well. Also, removal of patients from a zone where nerve gases are present and transporting them to a treatment center as soon as possible is very important. Moving right along, our next keyword is parathyroidectomy and intraoperative monitoring that commonly occurs during parathyroidectomy. So success of the resection of a parathyroid is measured intraoperatively by monitoring PTH, or parathyroid hormone. PTH has a very short half-life. It's about 2 to 5 minutes, and so with removal of the parathyroid glands that are secreting excess hormone, the PTH levels drop very rapidly. Recommendations for monitoring PTH levels include a pre-incision level, a pre-gland removal level, and a PTH level 10 minutes post-gland removal, or even more frequently. For example, our center measures PTH Q 5 minutes after resection of the overactive glands for 3 levels. Confirmation of resection is accomplished if the PTH levels decrease by 50% at 10 minutes from baseline, or having a normal or near normal PTH level 10 minutes after excision of the overactive gland. Intraoperative monitoring may also refer to the habit of surgeons of monitoring the recurrent laryngeal nerve, though this is often less vital during a parathyroidectomy than during a thyroidectomy. Some surgeons will monitor for recurrent laryngeal nerve injury during parathyroidectomy based solely on the location of the parathyroid glands. We'll move on to pediatric endotracheal tube sizing. So pediatric endotracheal tube sizing can be done based on equations which estimate sizes related to age, or by using leak pressure. Generally, this is done when using uncuffed endotracheal tubes. The standard equation for selecting an endotracheal tube is that an uncuffed endotracheal tube should equal age divided by 4 plus 4. If using a cuffed endotracheal tube, you can use the same equation, although you should take the result and reduce the size of the tube that you get from this by 0.5 to 1 full size smaller. If using leak pressure, an endotracheal tube is inserted and pressure using the APL valve is increased until a leak is noted around the tube. The goal is to elicit a leak somewhere between about 20 to 25 millimeters of mercury. If a higher pressure is required to obtain a leak, this indicates that the endotracheal tube is too large and may lead to tissue pressure injury or necrosis. And if the leak pressure is lower than this, it indicates that the endotracheal tube is too small and may place the patient at risk for aspiration due to an incompletely secure airway. In practice, now most prefer high volume and low pressure cuffed endotracheal tubes that will naturally ensure a cuff pressure between 20 and 25 millimeters of mercury without placing the patient at risk for aspiration once the endotracheal tube is in place. Our next to last keyword here is SOFA score calculation. If you look over to the right, you can see that SOFA score calculation represents a general gap in knowledge all throughout the country. It was actually on the Gaps in Knowledge report that the ABA recently sent out to the country. So what SOFA score is, it's short for Sequential Organ Failure Assessment. This is a score that is used to assess the severity of organ dysfunction in critically ill patients. When it was first created, it was mostly to look at patients who were suffering from sepsis, although it's been extrapolated to different patient populations as well. So the score examines 6 organ systems and then assigns a score to each one of these systems. They are the respiratory system, cardiovascular system, hepatic system, the coagulation system, the renal system, and the neurologic system. So in most cases, mortality is correlated with an increasing score, and the score is calculated at two different times. The first time is 24 hours after admission to the ICU, and then every 48 hours thereafter. Now, as you'll see here, each one of the systems has a value from 0 being normal to 4 being most abnormal, with a maximum score of 24. And we didn't provide a chart here that relates mortality to scores, but of course, as scores increase, mortality tends to increase. And somewhere in the mid to low teens, mortality begins to dramatically increase when looking at the SOFA score. All right, and thank goodness, welcome to our final keyword of part 2 of the review. It is medical malpractice and the elements that are required to prove medical malpractice. So we discussed this at our case conference this morning, and as you can see over to the right, this is a fairly big gap in knowledge across the country, although a little bit worse in our program. And so if a patient brings about a lawsuit trying to prove medical malpractice, they must do 4 different things. They must prove that 4 elements exist. So 1, they must prove that a professional duty by a physician was owed to them. That 2, that there was a breach of this professional duty by the practitioner. 3, that an injury was caused to them by this breach of duty. And 4, that the resulting damages from the injury were present and that they suffered in some way because of these damages. And so we can see from the little picture to the right here a little bit more about what these things mean. That medical duty of care was present, that there was a breach of this duty, that there was an injury to the patient because of this breach, and that also ultimately that there were damages based on this. Damages can be defined in any number of ways that we won't necessarily go into here, but in general that in some way the patient suffered damages. Okay, congratulations. We have reached the end of part 2 of the keyword review from this year's ITE. I included a picture here of what I'm sure you guys will look like running out of the testing center after your next ABA exam if you watch these videos, internalize the content, and keep working really hard at learning this really, really difficult material. Let me know if you need any help with anything. I'd be glad to sit down and talk with you guys. And best of luck as you continue on your academic journey. All right, we'll talk to you all soon. Take care.